All right, so tonight we are going to cover heart blocks and slow rhythms. And so this is the first of four of the series that we're going to do with EKG and ACLS, where we break down bradycardic rhythms, specific focus on heart blocks, tachycardic rhythms, cardiac arrest rhythms, and then the very last lecture of this month, which will actually be on February 29th, um, is going to be a 1 hour 12 lead EKG interpretation class. So hopefully tonight, if you come in with some struggle on heart blocks, one, it doesn't make you weird. If anything, it makes you normal as a paramedic student. It's probably the most difficult group of heart or EKG rhythms to really get a grasp on as a paramedic student. So if you are struggling with heart blocks, don't beat your head against the wall. Don't feel like you're struggling and no one else in your class is, because I can promise you that's certainly not the case. So we're going to take a real close look at heart blocks, look at the different rules, see how we can differentiate them. And we're also going to apply the symptomatic bradycardic algorithm. So for the sake of time, we are actually going to jump into the algorithm first, and then we are going to take our time looking at heart blocks. That way I can answer any questions that you all have as we progress through this. So moving right along. So when I teach ACLS, I like to teach ACLS in by putting every single EKG rhythm that we do into one of four buckets. So a slow bucket, a normal bucket, a fast bucket, or a dead bucket. Okay. And if you think about it, any type of EKG rhythm that we see can ultimately be categorized as either slow, normal, fast, or dead. And if you think about it that way of, okay, what is my EKG rhythm? Is it slow? Is it normal? Is it fast? Or is it dead? It helps you immediately put it into the right algorithm and follow that algorithm all the way down. Now, tonight we're just going to focus on the slow rhythms. um, so when we talk about slow rhythms, I'm obviously talking about rhythms that are less than 60 beats per minute. And not only do they have to be slow, but they also have to be symptomatic. Okay. So remember, and from an ACLS perspective, we only care about a rhythm in terms of treating that rhythm if it is both slow, meaning less than 60 beats per minute, and they are also symptomatic with that. Okay. Now let's talk about, what does symptomatic mean? It can mean a variety of different things. It could mean difficulty breathing, chest pain, altered mental status, hemodynamically unstable, which essentially just means low blood pressure or altered mental status. It could be dizziness. It could be lightheadedness. It could be palpitations. It could be a lot of different things. So anytime we have a bradycardic patient and they have some type of complaint to go along with it that we feel is an effect of that bradycardic rhythm, they are officially placed in that symptomatic bradycardia ACLS algorithm. Now, if I have a 22-year-old male, runs marathons all the time, I'm at his house for a whatever, for a headache or a broken finger, right? Something that I don't really feel like is associated with a low heart rate, and his heart rate's 55. It doesn't mean I'm really going to freak out and all of a sudden slam this patient with atropine, right? So we got to be cognizant of the fact of some people, especially younger people who are athletes, have naturally lower resting heart rates. So we got to keep that in mind. But we are talking about low heart rates, and they are symptomatic. They have to be symptomatic with these heart rates. So when we are talking about slow rhythms, some of those slow rhythms are, of course, sinus brady, junctional escape, or some people might call it junctional brady. Of course, our heart blocks. So we got a first degree, which we'll talk about, second degree type 1, second degree type 2, third degree. You can also throw idioventricular in there. So we got sinus Brady, junctional escape, first degree, second degree type 1, second degree type 2, third degree, and idioventricular. Did I leave anything out there? Did I leave any type of bradycardic rhythm out? I don't feel like I did, but if I did, please feel free to put it in the chat. So these are my slow rhythms. So my patient has to be in one of these rhythms, and they have to be symptomatic before I really care to do anything. Now, from this perspective, I'm going to further separate these rhythms out into two different groups, okay? And I'll talk about why. But I'm going to put it into two different groups. So what I'm going to do is I'm going to put sinus Brady here. I'm going to abbreviate that. I'm going to put junctional escape. I'm going to put first degree. And that's going to be in one category. And then over here, I'm going to do, actually, I'm sorry, I'm going to do second degree type 1 as well. And then over here in this column, I'm going to do my second degree type 2, my third degree, and I'll throw idioventricular in there as well. So with first degree block, and again, we're going to talk about all the blocks in great detail tonight, but with the first degree block, remember a first degree heart block is not a heart rhythm in and of itself. It is a facet of a heart rhythm. So we don't say, oh, the patient's in a first degree heart block. We do say that with a Winky block or a second degree type 2 or a third degree, but we don't say it with a first degree block. The first degree block is just an additional component of the rhythm that we are already seeing, right? So it is a normal sinus rhythm with a first degree heart block, or a sinus bradycardia with a first degree heart block. So the first degree heart block is just a component of that EKG strip. It's not the entire rhythm of itself, okay? So I've separated these strips here, these rhythms, into two different categories. Okay, and I'm going to change my ink color here. So I have sinus Brady, junctional escape, first degree, and second degree type 1, which is my Winky Bach. For these rhythms, when our patients are symptomatic and they are bradycardic, the very first medication that I am going to do is atropine, right? And we've talked about atropine. It hasn't been planned this way, but for some reason, atropine just keeps coming up from the previous two lectures that I've done. Atropine is a parasympatholytic. It blocks the parasympathetic nervous system from functioning so that my sympathetic nervous system can run unopposed. I can get my heart rate up. I can get vasoconstriction. I have that positive inotropy, chronotropy, dromotropy. I have all of those effects, right? Because atropine is my parasympatholytic. It's blocking my parasympathetic nervous system from working. So for those patients with those rhythms, my very first line medication or very first line intervention, I'll say, as long as the patient doesn't need oxygen, of course, oxygen always comes first. But my very first medication for this patient is going to be atropine. And I'm going to give that as 1 milligram every 3 to 5 minutes for a max of 3 milligrams total. So I can do that 3 times. Okay. If that doesn't work, I can go to transcutaneous pacing, which we will talk about. And then I can go to vasopressors if I need to. So that is my algorithm for these 4 rhythms. Okay. And in all reality, the symptomatic bradycardic algorithm, it is the same for every bradycardic rhythm. Okay. I've separated them out here because I'm going to talk about a better way to approach the second group. And it's not wrong per ACLS standards, and it's not wrong per your paramedic program. But I went ahead and separated these out, and it's totally fine to do that. And I feel like 99% of educators, I also feel like the National Registry is totally on board with the thought process here. Okay, it's been taught this way for a very long time. I'm not the first one to teach it this way. So that atropine 1 milligram every 3 to 5 minutes for a max total dose of 3 milligrams. That's what I'm doing for this first set of rhythms. If I don't have the effect I want, then I'm going to move on to transcutaneous pacing. Then I'm going to go on to vasopressors to try to get that that bradycardic heart rhythm up and to try to get my patient asymptomatic. So now with my second degree type 2, third degree, and idioventricular. So over here, we talked about atropine. Well, we're not going to do atropine on these patients. Is it wrong to do atropine on these patients? No, it's not wrong. Some of these patients might respond to atropine, but the majority of them probably won't. Okay. So the very first thing I'm going to do for these patients, if they're symptomatic, they're bradycardic, they're in a second degree type 2, third degree, or idioventricular, I am skipping the atropine and we are going straight to transcutaneous pacing. Okay. And then eventually, if my pacing doesn't work, I'm going to come down here and we will go to vasopressors. Again, we'll talk about this in more detail. All right. So transcutaneous pacing. So what does that mean? So we are externally serving as the pacemaker of the heart through the defibrillation pads. So I have to have the pads on, and I also have to have the limb leads on. You cannot pace a patient with just the pads on or just the limb leads on. You have to have the pads in place, and you have to have the electrodes in place as well. So the monitor needs to be able to actually see what's going on with the patient's rhythm while my defib pads are pacing the patient. So there's two settings that we have to worry about when we talk about a transcutaneous pacing. So it is our milliamps and it is our paces per minute. So from a paces per minute perspective, the AHA actually does give recommendation of starting around 60 paces per minute and increasing as needed. Okay. Now, what I would personally tell you if I was your paramedic instructor is I would personally start that patient off at around 70, maybe 80 paces per minute, because I'd like to get them a little bit higher than that threshold of being bradycardic. So I don't, 60 is fine. It's better than where they're at, right? If they're in this algorithm to begin with, but I just personally like to see them beating a little bit faster than 60. Let's try to get them around 70 paces per minute and see if we get their blood pressure up. Let's see if we fix their dizziness, right? Or their chest pain or whatever their symptoms are for us to be treating them in the first place. So AHA does give kind of some definitive recommendation there of that 60 paces per minute. Now, from a milliamperage perspective, there is no direct guidance from ACLS on this. So generally what educators will say, and again, it varies, but one of the more common things you'll probably hear is start at 20 or 25 and increase by 5 to 10 milliamps every 5 to 10 seconds. Okay. So milliamps start at 20 or 25, increasing your milliamps by 5 to 10 every 5 to 10 seconds until what, right? So we are doing that until we get, let me erase some of this, until we get mechanical and electrical capture. Okay, you have to know what these mean. So mechanical capture, that is, there is a pulse that you can palpate that corresponds with your rate. Okay, so if I'm pacing this patient at 70 paces per minute, mechanical capture would be when I put my hands on the patient and I'm checking a radial or a brachial or femoral, whatever you're checking, right? When I'm palpating for that pulse, it aligns with 70 paces per minute. It matches up with what I'm pacing the patient at. That is mechanical capture. The other type of capture that I mentioned is electrical capture. Okay. And electrical capture means that I have a wide, I'm sorry, let me erase that. I have a pacer spike. Got ahead of myself. So I have a pacer spike, and immediately following that is a wide QRS complex. Okay. So mechanical capture is the patient has a pulse, and I can palpate that pulse for how many paces per minute I am delivering. Electrical capture is I have a pacer spike on the EKG that I'm looking at on the monitor, and immediately after that pacer spike, I have a wide complex QRS. Now, the reason that is a wide QRS complex is because we are actually serving as a ventricular pacemaker at that point. We are physically causing the ventricles to squeeze and to contract and to depolarize with our external pacemaking, which gives us that wide complex QRS. Okay, so we have to have both of these in order for our transcutaneous pacing to be effective. Okay, so 20 to 25 milliamps, increasing every 5 to 10 seconds by 5 to 10 milliamps until I get mechanical and electrical capture. And if you are regurgitating that in a scenario in the lab, that is exactly how you need to say it. I'm going to start my patient off at 60 to 70 paces per minute. I'm going to start my milliamps at 20 to 25, increasing by 5 to 10 every 5 to 10 seconds until I get mechanical and electrical capture. And you better be prepared to explain what mechanical and electrical capture are when you say that. So I'm going to erase. Oh, I got a question. Let me jump and see what that is. So what would happen if you don't have both by some chance is the question. So if you don't have both, you're probably not effectively, that's a great question. You're probably not effectively pacing the patient. Okay. Now, because if we are not going to be effectively contracting the ventricles if I don't have electrical capture, right? If I don't have that pacer spike immediately followed by that wide QRS complex, I am not effectively capturing the ventricles for my depolarization. And then, of course, the easier one to figure out, if I don't have mechanical capture, if I can't palpate the patient's pulse and it doesn't align with what I'm trying to pace them at to begin with, well, that's obviously a big problem, right? So if I can't capture it, and just know that there's a good chance you're not going to start to get electrical and maybe even mechanical capture until you're around like 80, 90, even 100 milliamps, okay? So don't be surprised if you're like, oh my God, I started at 20, I'm at 75, I'm still not getting there. Keep going, right? As you get closer to 100, you'll probably start to get capture on that patient. So once we set up our pacemaker, if it doesn't work, then essentially what we're going to end up doing, and I'm going to erase this, and again, remember it's recorded, and I'll throw up the recording so you can go back and watch it. So if my pacing doesn't work, or for some reason it's inadequate, I can't get good electrical mechanical capture, then we are going to go to vasopressors. Okay. So that's kind of our last ditch effort. That's us dropping back to punt. This is when we're going to do our vasopressors. And this is where we're going to get into our push dose epi or our epi infusion of 2 to 10 mics per minute, or our dopamine, which is kind of falling out of favor, but it's still in the algorithm at 2 to 10 micrograms per kilogram per minute. So those doses are very similar to one another, obviously. Don't get them confused. Our epi is 2 to 10 mics per minute. Our dopamine is 2 to 10 mics per kilo per minute. Dopamine is a weight-based medication. Don't get that confused on a test. All right, so I was just checking out another question, and we're going to get to that question here in a moment. So any questions about the slow or the symptomatic bradycardic algorithm? So again, sinus Brady, junctional escape, first degree, second degree type 1. We're going to jump over here to atropine first, and then we can go to pacing, and then we can go to vasopressors. As I go to my second degree type 2, third degree and idioventricular, I'm skipping atropine, and I'm going over here to my pacing and my vasopressors. So, and I'm going to explain that here in a moment, but I want to give an option to ask some questions if there are any at this point. Atropine isn't wrong for these. Okay, atropine isn't wrong. It's not going to kill your patient. You're probably just not going to get the effect you're looking for. All right. So I don't see any questions. So let's talk about why for that second degree type 2, third degree, and idioventricular, why we go straight to pacing with those rhythms. Okay. And again, excuse me, it's hard to write on a totally vertical screen here. So with a second degree type 2, third degree, and idioventricular rhythms, first off, idioventricular obviously is a ventricular rhythm, right? So my ventricles are driving the rate. Atropine is a parasympatholytic. It blocks the parasympathetic nervous system from running, so my sympathetic nervous system can run unopposed. My sympathetic nervous system is going to speed up conduction from my SA to my AV node, down to my bundle of His, my bundle branches, and my Purkinje fibers. Okay, so that's how it would work under normal circumstances if we are using atropine. With a second degree type 2 and third degree heart block, those are called high degree heart blocks. Okay, I'm going to abbreviate that. So those are considered high degree heart blocks. Idioventricular, we already talked about, is being driven by the ventricles. If my ventricles are driving the rate and the rhythm, the speed of impulse conduction from my SA node, my AV node, really isn't going to do me a ton of good at that point, right? Because my ventricles are totally driving the bus. Now, with a second degree type 2 and a third degree heart block, these are high degree heart blocks. Here's your heart. Remember, your heart looks just like that, right? So here's your SA. I wish I would stop doing that. Here's your SA node. Here's your AV node. Here's your bundle of His. Here's your bundle branches and your Purkinje fibers that innervate your ventricles there. Under normal circumstances, that SA node fires off to the AV. The AV node and the AV junction then decide to pass that down to the bundle of His, where that impulse conduction continues down the bundle branches and your Purkinje fibers, right? And as that process naturally occurs, I get atrial contraction and I get ventricular contraction or depolarization. Now, in a high degree heart block, which is a second degree type 2 or a third degree block, I have a blockage high up in the conduction system. Okay. Now, we can't pinpoint it necessarily, but what we can do is generalize it. So if I have a high degree heart block somewhere in this area, somewhere around my bundle of His, maybe it's above it, maybe it's below it, my SA and AV node can work their butts off. They can send impulses down the line as much as they want to, as fast as they want to. But if there's a blockage here, it really doesn't matter, right? It's like if you're sitting out on the interstate and you're stuck in traffic, the interstate shut down, and you're sitting there beeping your horn, yelling at everybody, telling them to get out of your way. You can do that all day long if you want, but it's not going to get you through the traffic jam any faster. Okay. So it's kind of the same principle with atropine. Sure, I can give this patient atropine. We've already said atropine is not going to kill these patients. It's just probably not going to have the effect that you want. So, yep, we give atropine. It speeds up conduction from my SA to my AV, and then boom, it gets stuck right there in that high degree heart block. Sometimes the conduction gets through, sometimes the conduction doesn't get through. Okay. So that's why it's generally a quicker and more effective option to put the pads on these patients and to send electricity across the entire myocardium to get that atrial and ventricular depolarization that we need. Okay. So with a high degree heart block, that blockage is high. They are very solid heart blocks. They are not going to let too many impulses through. They're definitely not going to let them through with too much regularity or consistency. And because of that, atropine generally isn't effective on those patients. And that's why we go straight to transcutaneous pacing with those patients. Okay. Hopefully that makes sense. If it doesn't, please let me know. All right. So now we are going to move on to, so the question is, would you say the high degree blocks are prevalent more on one side, left or right, or no difference? To be honest, I don't know the answer to that question, Richard. I don't, I don't, I think they're happening typically higher up than the bundle branches, right? It's like an AV junction or bundle of his issue. So it's not necessarily a bundle branch block like we would expect to be able to identify on a 12 lead EKG. These are more of higher up conduction blocks that are just simply not letting those impulse conductions to go from the SA to the AV through the bundle of his to even get to the bundle branches to begin with. So they are not the same as a bundle branch block. Don't get that confused. All right, so we are going to move on and talk about blocks now. Okay, so atrioventricular block rhythms. I said this in the very beginning, and a few people have jumped on since I said it, so I'll say it again. If you struggle with heart block, you are not alone. You are certainly not the only paramedic student in your program that struggled with these or are struggling with these. It makes you totally normal. In fact, I would say if the first time you were taught heart blocks, you picked it up with no problem at all, that would make you less normal because a lot of paramedic students don't get it that quickly. So we've already talked on this, but remember the AV junction provides the electrical link between the atria and the ventricles. An AV junction is not often pointed out in these pictures, but we're essentially saying it's at the level of the AV node, okay? So the atrioventricular node, that is where our blocks are occurring. It's somewhere around that AV node in that bundle of his. So a first degree AV block. Remember, a first degree AV block is not a rhythm in and of itself. It is a facet of a rhythm. So it's like PVCs, right? We don't say the patient is in PVCs. We say it's a normal sinus rhythm with PVCs or sinus tachycardia with PVCs. It's the same thing for this. It's a sinus bradycardic, sinus bradycardia with a first degree AV block, or normal sinus rhythm with a first degree AV block. The first degree AV block in and of itself is not a cardiac rhythm. So the biggest defining thing here is the PR interval. Now I'm going to give you a little hint. The PR interval is really what I'm going to talk about and focus on for the remainder of this presentation, because the PRI is going to tell you what type of block you have, period. So a first degree AV block, it is a block where the PRI is prolonged. It is greater than 0.20 seconds or greater than 5 small boxes on the EKG paper. Okay, so remember, we count the PR interval from the beginning of the P wave to the beginning of the QRS complex or the R wave, depending on what the morphology is. So bear with me here as I'm drawing on a computer screen. So these are my PRIs loosely. So that is greater than 5 small boxes, greater than 0.20 seconds. That is a first degree AV block. Now, what is this actual rhythm? Let's assume it's a 6-second strip. I have 1, 2, 3, 4, 5, 6, 7, 8. 8 times 10 is what? 80. So I have a normal sinus rhythm with a first degree AV block. Okay. So a PRI that's longer than 0.20 seconds. It's always going to be longer than 0.20 seconds. It's going to be very regular looking. That is a first degree AV block. Now, a second degree type 1 heart block is a winky block. Okay. And we're going to look at a few examples of this, a few practice strips as well. So with a winky block, let's look at the PRI. The PRI lengthens with each cycle until a P wave appears without a QRS complex. So my PRI starts off here and gets a little bit longer, a little bit longer, a little bit longer, I drop a beat, which means I lose a QRS complex, and that pattern starts over again. Small PRI, a little bit longer, a little bit longer, a little bit longer. I drop a beat, starts over again. That is my second degree type 1 or my Winky-Bach rhythm. Okay. Now, don't get confused. And this happened to students that I've taught because I always teach it as it gets longer and longer and longer, and you drop a beat and it starts over. It doesn't have to have 3 different beats getting longer and then dropping a beat. It might be 3, it might be 5, it might be 2. Okay. But the overall principle here is my PRI is lengthening, and it's lengthening from beat to beat until it drops a beat or loses a QRS complex and restarts. All right. So let's look at this rhythm here. So as you can see, this first PR interval, let me change colors so you can see it a little bit better. So here's my first PR interval. So I have about 4 boxes there, if you count in those hashes. So I have about four boxes, which would be a 0.16 PR interval. As I go to my next PR interval, I'm definitely longer. I'm at about 1, 2, 3, 4, 5, 6. So I'm about 4 there, 6 there. And as I go to my next PRI, 1, 2, 3, 4, 5, 6, 7, 8. And then boom, here's a P wave. It's missing a QRS complex. So there is my dropped beat. And I'm starting back over with this same pattern again, right? 1, 2, 3, 4. 0.16 is my PR interval. So again, if I could just draw this strip out for an infinite amount of time, my very next PR interval would probably have about 6 small boxes. Then my next PR interval would probably have about 8 small boxes. And then I would probably drop a beat. And then I would start back over at 4 again, or somewhere real close to that. Okay. So with my second degree heart block, my type 1, my Winky-Bach, my PR interval is getting longer and longer and longer until it drops a beat, meaning I have a P wave and no QRS complex. And then that cycle starts all over again. That is a second degree type 1 or a Winky-Bach. That is not classified as a high degree heart block. Okay, so those patients will generally react really well to atropine if they're symptomatic and bradycardic. Now let's talk about my second degree type 2. Look at your PRI. So let's look at this rule. Your PR interval is within normal limits or might be a little prolonged, but it is constant for the conducted beats. So for every QRS complex, the P wave before it, that PR interval is the same for every conducted beat that we see. Okay, so let's look at this strip. We immediately see that we have more P waves than we have QRS complexes, right? P wave, P wave, P wave, 1 QRS, P wave, P wave, P wave, 1 QRS, and so forth. So when I have more P waves than I have QRS complexes, that means I have a heart block. That alone does not tell me what type of heart block I have, because as we just saw in our Winky-Bach, I have more P waves than I have QRS complexes, right? Not in every single part of this strip, but I do have more P waves than I do QRS complexes, right? And here's that example. I have a P wave, I have a P wave, and I have 1 QRS complex. So just because you see more than 1 P wave doesn't mean it's this type of rhythm. It just means it is a heart block. Now we have to look at the PR interval to determine what type of heart block is it. All right. So for this, we already said we have more P's than QRS's, which indeed we do. And our PR interval for every conducted beat is the same, which means if I measured this PR interval and this PR interval and this PR interval and the one that's down here, those PR intervals are all the same as one another. Those measurements are exactly the same as one another. I have more P's than QRS's. It's a block. Look at my PR interval. Is it getting longer and longer and longer until it drops a beat? Nope. Is it the same for every QRS complex? Yes, it is. It has to be a second degree type 2 heart block. That is a high degree heart block, and that is the rhythm that one of the rhythms that we would consider just going straight to transcutaneous pacing to try to fix, because atropine may or may not be effective with these patients. All right, third degree heart block. Do I have more P waves and QRSs on this strip? 1, 2. I have 2 P waves. I have 1 QRS. 1, 2. I have 2 P waves. I have 1 QRS. So yes, I do. It's a heart block. Don't know what kind because I haven't looked at any other rule, right? But I know it's a heart block. So next, what I need to do is I need to look at the PR interval. With a third degree heart block, there is going to be no pattern or no correlation from my P waves and my QRS complexes on the strip. They're not going to be getting longer and longer until they drop. They're not going to be the same for every QRS complex. They're going to be completely all over the place. There's going to be no rhyme or reason as to what my P waves are doing and what my QRS complexes are doing. So, for example, here's a PRI. I have a dropped beat here. Here's a PRI, super long. Here's another P wave, right, with no QRS complex. Here's an incredibly long PR interval, if that's even what you want to call it at that point, which it is by the book. But that P wave is having no correlation. It's having no effect on my QRS complex at all at that point. Okay. So in a third degree heart block, it's also called a complete heart block. My P waves are doing their thing. My QRS complexes are doing their thing. There's no rhyme or reason as to what these things are doing. They have no relationship with each other whatsoever. That is a third degree heart block. So do I have more P's than QRSs? Absolutely, I do. Is my PRI constantly getting longer and longer and longer until it drops a beat? No, it's not getting longer and longer and longer until it drops a beat. My measurements are, let me look at this question real quick. My measurements are all over the place, and I have dropped beats everywhere. Okay. Now, if you get confused on, is it a third degree heart block or is it a second degree type 1, a winky block, look at the regularity of the underlying rhythm. Excuse me. With a winky block, it is going to be an irregular rhythm. Okay. Because I'm dropping a beat. So here's a QRS, here's a QRS, here's a QRS. So far, I'm looking good. Oh, I don't have anything here, right? That's a problem. So I got to come down here. A winky block is an irregular rhythm. My QRSs are not going to march out from one another. I'm not going to have a regular R to R. There's going to be a dropped beat in there. Okay. A second degree type 2 is generally always going to be regular from a QRS perspective. A third degree heart block is generally always going to be regular from a QRS perspective in terms of marching out the R to Rs. Okay. So someone asked, is a third degree heart block typically slow? And the answer is yes. A third degree heart block out of all the heart blocks is the worst to have. And it is going to be a very bradycardic rhythm. Okay. Because if you think about it, when I have a second degree type 2 heart block, and I'm trying to go back, but it won't let me here. When I have a second degree type 2 heart block, I still have a relationship with my P waves and my QRSs. So my atrial rate isn't driving the ventricular rate entirely, but there's still some relationship there. But when I get to my third degree heart block, there's no relationship whatsoever. So if my ventricles are driving the rhythm and the rate, I should say, not the rhythm, but the rate, we know that usually your Purkinje fibers can only really put out an intrinsic rate somewhere between 50 and 40 beats per minute, right? So generally with these third-degree blocks, they're probably going to be pretty slow rhythms. They can be a little bit faster than that, but they're going to be some pretty bradycardic rhythms that they're going to be some pretty sick patients with these. So let's sum this up here. With a first-degree AV block, the PR interval is this greater than 0.2 seconds. Okay, it's not a rhythm in and of itself. It's just a facet of a rhythm. It's a normal sinus with a first-degree heart block, sinus tach with a first-degree heart block. It just has a prolonged PRI that's greater than 5 small boxes. A second-degree type 1 or a winky block. This is where my PR interval gradually gets longer until a QRS is dropped, and then it resets itself and it does it again, and it resets itself and it does it again. A second degree type 2 or a Mobitz 2 is when my PRI is regular. I'm going to have more P's than QRSs, but for every QRS complex, for every conducted beat, my PRI is going to be exactly the same. Okay. And then lastly, with my third degree heart block, there is no relationship between my P waves and my QRS complexes. Therefore, there is no relationship with my PR interval across that strip. It's not consistently getting longer until we drop a beat. It's not staying the same for every conducted beat. My P waves are doing their own thing. My QRS complexes are doing their own thing. Okay. So once you recognize this is a block, which I don't think that is the issue many paramedic students face. I think most paramedic students can realize, yes, this is a block. Then the fear sets in of, oh my God, what type of block is this? Look at the PR interval. The PR interval will literally tell you what type of block it is. It's either consistently long for every beat and it stays the same, which would be my first degree. It's getting longer until it eventually drops a QRS complex and restarts. It's the same for every QRS complex, or there's no relationship at all. It's totally chaotic. All right, those are the rules for heart blocks. So let's look at a few practice strips, and that'll be all I have for tonight. So what do we have here? And feel free to put it in the chat. I'll give you a second to look at it. So this is a first degree heart block. Okay. Here's my P wave. Oh, that was kind of a bad marking. Here's the beginning of my P wave. There's the beginning of my QRS. Beginning of my PRI, into my PRI. Beginning of my PRI, into my PRI. Right? And we do that throughout the strip. It is significantly longer than 5 small boxes or 0.20 seconds. And it is the same for every QRS complex that we see. That is a first degree AV block. Okay. Now, what would you call that? 1, 2, 3, 4, 5, 6, 7. That is a normal sinus rhythm with a first degree AV block. That is how we accurately interpret that rhythm. All right, next. Actually, I'm going to screw you guys up. I'm going to skip that one. Let's look at this one. And this one's a little tricky too, but remember the rules. Okay. Remember, I said second degree type 2 and third degree are typically regular. They certainly don't have to be, but generally they will be when you see them on exams for practice strips and even when you see them in the field, but they don't have to be. But the first step is recognizing there's a problem, right? The first step is recognizing I have a heart block. The second step is going to the PR interval and identifying what is it doing? What is the relationship? Is it getting longer and longer and longer until it drops a beat? Is it the same for every QRS complex, or is it all over the place? So let's look at this one. Is it a block? Yes, it's a block. How do I know that? I have a dropped beat. I have more P's than I do QRSs. This is a heart block. So let's look at the PR interval. So if I look at my PRI, for every conducted beat, is that getting longer and longer and longer until we drop? It's not. Is it totally all over the place? Is it 0.12 seconds to 0.24 seconds to 0.16 seconds to 0.04 seconds? No, it's not, right? It's not all over the place. I would say these PR intervals are very consistent with one another. So what type of block does this have to be? It's not a second degree type 1 because it's not getting longer and longer and longer. It's not a third degree because my PR intervals aren't all over the place. So it is a second degree type 2 heart block. Don't let the regularity of the rhythm throw you off. And this is why I wanted to point that out when we were going through it. And that is why I specifically said don't get confused by like a second degree type 2 and a winky Bach, or a third degree and a winky Bach, because you can see them be irregular. It's not often you see them, but you can see them be irregular. But don't let it freak you out. Is it a block? Yes, it is. What's happening at the PRI? The PRI is going to tell me what type of block it is. That is the answer to the test, right? Look at the PR interval. Your answer is right there. It is the same for every conducted beat. It's the same for every QRS complex. It is a second degree type 2 heart block. Okay, so let's look at this one. So step 1, is it a heart block? Absolutely it is. There's my extra P wave right there. That's all I need to call it a heart block. I have more P's than I have QRSs. Okay. So it's definitely a heart block. Somebody said Mobitz. Which Mobitz? So remember, there's a Mobitz type 1 and a Mobitz type 2. So there's a second degree type 1 and a second degree type 2. These blocks have too many names. I understand. They get confusing. So it is a Mobitz, but is it a Mobitz 1, meaning a winky Bach, or a Mobitz 2, meaning a second degree type 2? Good. Yes, you are correct. Both of you are correct. So it is a Mobitz type 1, or a second degree type 1, or a winky Bach, whatever your flavor is. That's what it is. Okay. I have more P's than I have QRSs. When I measure the PRI, I'm getting longer and longer and longer until boom, I drop a beat. Now I start all over again. Right? My pattern resets itself. I'm getting longer and longer. And then if I was a betting man, I would say I drop a beat, and then I have a P wave and a QRS here. That is a second degree type 1. Will this patient respond favorably to atropine? Probably. It's not a high degree heart block. They will probably respond really well with atropine if they needed it, if they were symptomatic and bradycardic. Okay, which this person's right at 60 beats per minute. So depending on how he or she is presenting, they're probably not a symptomatic bradycardic patient to begin with. But it is a second degree type 1 winky Bach rhythm. Great job. What about this? I feel like this is the last one, but I could be lying to you. Might have one more. Somebody answered. Yes, good. That is a third-degree heart block or a complete heart block. So why? Right? And this was a little bit more difficult to pick out the extra P waves because they're largely kind of buried in our T waves and our QRS complexes, right? So our P waves are actually probably these. We have a P wave there. But if we look at our PR interval, here's a good PRI to go off of. And here's a PRI. What just happened there? Oh man, now I'm back to splitting the distance here. And now I'm right back at the QRS complex again. And now I'm way far away from the QRS complex again. There's no rhyme or reason. They're not getting longer and longer and longer until they drop a beat. They're not staying the same for every single conducted beat and every single QRS complex. They are all over the place. There's no rhyme or reason as to what's happening with that PRI. So that is a third-degree complete heart block, a high-degree heart block that we probably need to go straight to transcutaneous pacing for, depending on how the patient's doing. Okay. That is all I have. So again, all this is recorded. I'll throw up the recording tomorrow, so you guys can watch it again if you want to. Hopefully it was helpful for anyone who was struggling with heart blocks to begin with. And again, I think that's probably the most intimidating set of rhythms there are in paramedic school, which is why I chose to do them first. They really don't have to be that difficult. Recognize it's a block, which again, I'm confident all of you can do. And then it's just look at the PR interval. Remember what happens with the PR interval for these 3 or 4 different blocks. That is going to tell you what type of block it is. It's getting longer and longer and longer. It's staying the same, or it's all over the place. Those are the options. Okay. So hopefully this is helpful. I'll stay on for a few minutes to answer any questions that you all have. Otherwise, feel free to jump off. Thank you all again for jumping on. Next week, we're going to look at, I believe it's tachycardic rhythms. So we'll look at SVT, VTAC with a pulse, both stable and unstable. And we'll talk about AFib with RVR as well, and what we should do with those rhythms from an ACLS perspective. Okay. Thank you very much. I appreciate you all. Thank you. You all have a good night. Have a good weekend, and I'll see you next week.